to the diagnosis, management of metabolic bone diseases, PTH, vitamin D, and bone turnover markers, BTM. It's important that laboratory professionals are familiar with the clinical applications of these important analytes. I am the chair of this webinar. My name is Samuel Vasikaran, and I'm also the first presenter. And I will be presenting on bone turnover markers. I hope you can see the slides and see me presenting. I'm trying to get the slides to work, so I'll try again. Okay, I think we are ready to start. So the title of my talk is Role of Bone Turnover Markers in Management of Metabolic Bone Disease. Now, I've given a summary of my presentation. I'll start with physiology and chemistry of bone turnover markers, the reference bone turnover markers in osteoporosis, pre-analytics, analytics, reference intervals, clinical use of bone turnover markers in osteoporosis, and then briefly CKD, MBD, and Paget's disease of bone. The adult skeleton is constantly being remodeled in order to maintain its strength and structure. Whenever there is a micro damage or a microfracture in the skeleton, that area is targeted for remodeling. So the whole skeleton is continuously being remodeled and renewed to maintain strength and structure. And this remodeling cycle starts with osteoclasts attaching to areas that need remodeling, like areas of microdamage, and the osteoclast then excavating a cavity, an resorption cavity. Once that's finished, osteoblasts migrate to that cavity, line the cavity, and form a new osteoid, which is then mineralized to form new bone. In this way, old bone is replaced with new bone. If the amount of new bone is equal to the amount of bone that was resorbed, then skeletal mass is maintained and health is maintained. In postmenopausal osteoporosis and in old age osteoporosis, the amount of new bone formed doesn't always equate to the amount of bone resorbed. And then over time, gradually over the skeleton, there is loss of bone mass, and this leads to reduction in bone mass and bone density, leading to osteoporosis and loss of bone strength. Now, the theory of bone turnover markers is the amount of bone turnover markers released during bone remodeling reflects bone remodeling activity. So bone formation markers and bone resorption markers in blood and urine reflect bone formation rate and bone resorption rate. And by measuring these in blood and urine, and more recently, mostly in blood, we can assess bone remodeling and specifically bone formation and bone resorption. There are a number of bone turnover markers that have been studied over time, and I'm just listing here a few of the more important ones. Procollagen N-terminal extension peptide P1NP, bone-specific alkaline phosphatase BALP, and osteocalcin are bone formation markers. These are released during different phases of bone formation, whereas bone resorption markers are degradation products of bone collagen, such as C-terminal telepeptide or beta-CTX, N-terminal telepeptide NTX, and deoxypyridinylate DPD, as well as tartrate-resistant acid phosphatase 5B, which is an enzyme released by osteoclasts. So these are the markers that we will focus on today. The reference bone turnover markers in osteoporosis, and this is for osteoporosis, were designated by ifcc in conjunction with the International Osteoporosis Foundation in 2011. And the reference standard marker for bone resorption was designated beta-CTX in blood, and the reference standard marker for bone formation is serum P1NP. And at that time, this is more than 10 years ago, we encouraged researchers to use these markers to study bone formation and bone resorption and accumulate data so that they can be used well for management of osteoporosis. Subsequent to that, a number of papers have followed on, and I'm just showing you this paper on pre-analytic aspects for bone markers, specifically touching on CTX and P1NP as the reference bone turnover markers. And they have given details of the pre-analytics for these two markers. Standardized collection is requested to avoid effects of food and circadian rhythm, which is important for CTX. So morning fasting specimen is collected, and CTX is more stable in EDTA. P1NP is a lot more robust and has less circadian variation or effect of diet. However, if we are measuring both together, you would collect the sample in the morning in the fasting state. Both P1NP and beta-CTX are available on two automated systems, the Roche system and the IDS ISIS. So for P1NP, the two assays are somewhat different. The Roche assay measures total P1NP, whereas the IDS ISIS system measures the intact P1NP only. Total P1NP consists of intact P1NP plus monomeric fragments. These fragments accumulate in renal failure, and therefore the measurement in renal failure by a total assay gives artifactually elevated P1NP levels, whereas the intact P1NP is not affected by renal failure. There are also manual assays. For P1NP, there's an RIA, Orion Diagnostics, and that's FDA approved in the USA. And then ELISA is available for CTX. The CTX assays on the two automated platforms use the same standard. So they are similar in what they recognize. However, I'll show you they, in fact, do not give similar results. So for P1NP, even though the two systems, the two automated systems, measure intact or total P1NP, they in fact give similar results in patients with normal GFR. However, the Orion RIA gives different results, so that cannot be used interchangeably. With CTX, the two automated platforms give different results, so they're not harmonized. And ifcc is working on harmonizing these assays. So it's important that when patients have CTX measured, that the same assay is used for sequential measurement. As I've already indicated, EDTA plasma is the preferred sample for CTX due to its fragility. Reference intervals, there are a number of studies which have been published for P1NP and CTX, and I've just given you a list of some of the assays. The reference interval in premenopausal women, and for P1NP, roughly the levels are around between 15 and 60 or 65 nanograms per mil. Here in Australia, we have published harmonized Australian reference intervals for serum P1NP and CTX, and I've given you the table here for serum P1NP in adult males and females. We got different intervals for males, young males and older males, and similarly for females. These reference intervals can be used for the Roche assay as well as the IDS-ICIS assay because they are harmonized. For CTX, again, a number of publications on reference intervals are available, and roughly the values for premenopausal women range from 100 to 600, 650 nanograms per liter, note the units. And again, the harmonized Australian reference intervals for CTX is given here, and it's been published in Clinical Biochemist Reviews. And as you can see, there's some difference between young and old, or male and females. So I'll move on to clinical application. So what are the clinical needs in osteoporosis? First of all, diagnosis of osteoporosis. There's really no role for the laboratory in diagnosis of osteoporosis. Osteoporosis is diagnosed by bone density measurement, BMD scan, and there are cutoffs used for diagnosis of osteoporosis by BMD. A clinical diagnosis of osteoporosis can be made in patients with minimal trauma fracture. That's a clinical diagnosis. So there's no role for laboratory testing for the diagnosis of osteoporosis. What we then, once osteoporosis is diagnosed, what we want to do is to identify individuals who would benefit best from treatment. So these are patients with osteoporosis or even osteopenia, but high risk. And for that, we use fracture risk algorithms. FRAX is the most widely used fracture risk algorithm. And currently, bone turnover markers are not used in these, or not included in these algorithms due to lack of data on how they interact with other risk factors. Therefore, I will not discuss that further. The use of bone turnover markers in fracture risk calculation is awaiting further study. The main use of bone turnover markers in osteoporosis is in monitoring to monitor response to treatment, and also offset of treatment when treatment has been ceased. So as I mentioned, identification of individuals for treatment, bone turnover markers are not used. They're really used for monitoring treatment and cessation of therapy. But you need to know the change in bone turnover markers following treatment to see, for you to assess how well treatment is working. So following anabolic agents, and really there's one anabolic agent that's teriparatide or PTH analog. There are a couple of different forms of these available, and they improve bone formation. And so with the initiation of treatment, there is a major increase in bone formation markers, and here you can see P1NP increasing, followed by a smaller increase in bone resorption markers. That's due to coupling. Bone formation and resorption are coupled, and therefore there is an increase in bone resorption markers. Most treatment in osteoporosis are anti-resorptive treatments, and most commonly used are bisphosphonates, and they inhibit osteoclast action, and initiation of treatment leads to a decrease in bone resorption markers, again shown here in the lower diagram. NTX decreases first, and because of coupling, there is a reduction in bone formation markers as well. However, the reduction in bone formation is less than the reduction in bone resorption. This leads to an increase in bone density and reduction in fracture risk. The route of administration of bisphosphonate determines the BTM response as well. So as you can see in this diagram, the CTX levels decrease quite drastically following intravenous zoledronic acid, as opposed to a slower and shallower reduction following oral alendronate treatment. So what are the treatment targets for monitoring? So there are two ways you can monitor. Look at the reference change value and see if the marker has changed greater than the reference change value. Or treatment targets can be used, and they are evidence-based, based on clinical trials where they've been shown to be associated with a lower reduction in fracture risk. And generally, it's the lower half of premenopausal range, or less than the median of the premenopausal range. That's the target. So as an example, for serum CTX, you expect a greater than 30% decrease, which amounts to about 100 nanograms per liter reduction, which confirms that the patient is responding to treatment and that the patient is actually taking the treatment as well as responding. The treatment target, as I mentioned, is less than the premenopausal median, and for serum CTX, it's 300 nanograms per liter. Depending on the assay, as I mentioned, there is some lack of harmonization between assays, so it has to be assay specific, but it's roughly around 300 nanograms per liter. For serum P1NP, even though it's a formation marker, you can in fact use for monitoring anti-resorptive therapy. Reference change value is 10 micrograms per liter, and the target is less than 35 micrograms per liter. So this is for anti-resorptive bisphosphonate treatment. Denosumab, a newer anti-resorptive, shows greater change in bone turnover markers, and most patients on denosumab treatment would have their levels well below premenopausal median. So serum CTX less than 200 nanograms per liter, and P1NP less than 20 micrograms per liter. For anabolic therapy, we just use a reference change value of 10 for P1NP. We only use a bone formation marker. So monitoring offset of treatment, bisphosphonates are used for about 5 years and then ceased. And then you monitor these patients to see if their bone turnover markers remain low enough to for them to remain off treatment. And once the bone turnover markers start increasing, and especially if they increase to above the median or premenopausal median, you may consider starting another course of treatment. Denosumab is somewhat different. Cessation of denosumab therapy, and denosumab is given parenterally subcutaneously and 6 monthly. Once you stop treatment, there's a rebound increase in bone turnover markers. It goes above baseline, and it has been associated with increased fracture risk. So the recommendation now is, right, once you start treatment, you can't just stop treatment with denosumab without further management to stop this rebound increase. And the current recommendation is when you stop denosumab treatment, the patient should be started on bisphosphonates for a period of time, depending on how long they have had denosumab treatment for, and also monitor them with bone turnover markers to make sure that their bone turnover markers are suppressed. The newest medication is romosozumab, which is a sclerostin antibody therapy, and it's got dual action. It increases P1NP and decreases CTX, which is ideal. So studies have shown that these are dual action agents, romosozumab, and they have started being used for osteoporosis with very good effect. However, the use of bone turnover markers for monitoring romosozumab is yet to be determined. I'll move on to CKD MBD, just to say that the reference bone markers I mentioned are really for osteoporosis. For CKD MBD monitoring, PTH with or without bone alkaline phosphatase is used to evaluate bone turnover. PTH is routinely used to make sure that the patient doesn't have a dynamic disease or a very high bone turnover. And bone alkaline phosphatase is also recommended as a marker because it's not affected by renal failure, and it has been shown to have some value in determining bone turnover in CKD-MBD. Other potential markers are those which are not affected by renal failure, like intact P1NP, as well as tartrate-resistant acid phosphatase 5B, and it shows a lot of promise for future use in CKD, MBD, and other bone diseases. Finally, metabolic bone turnover markers in diagnosis and monitoring of Paget's disease. Paget's disease is diagnosed in patients who usually present with either fractures or bone pain or bone deformity, and X-rays and isotope bone scans are used to diagnose it, together with bone turnover markers, which are increased in active Paget's disease. So Paget's disease bone turnover markers are usually very high, so total alkaline phosphatase is adequate in most cases. If not, bone alkaline phosphatase or P1NP may be used for diagnosis and also for monitoring. So with treatment, again, anti-resorptive treatments used for treating Paget's disease, and the aim is to normalize bone turnover markers and ideally into the lower half of the reference interval. I will stop with this, and what we're going to do is I'm going to introduce the next speaker, and then after the third speaker, we will have all the questions discussed together at the same time. So the next speaker is Professor Hans Schneider from Melbourne, Australia. Professor Hans Schneider is a chemical pathologist and an endocrinologist and clinical professor at Monash University. He hails from Heidelberg in Germany, but he's an Aussie, real Aussie, and he's been with us for a long time in Australia. So I'm going to stop sharing my slide, and I'm going to invite Professor Hans Schneider to load his slide. So thank you, Hans. You can take over now.
I'm trying to share my slide. And clearly I'm still having a problem. with it. I might cancel. Just, Sam, I still have your screen.